Good morning and welcome to today's presentation. Our speaker today is Dr. Nicole Rossum. Dr. Nicole is a qualified hematologist currently working at Ampath laboratories in the Department of Genetics. She has an interest in precision oncology and flow cytometry. She obtained her MMED and FcPath hematology at the University of the Free State in 2016. Thank you so much for coming to present to us.
Thank you for having me. Good morning, everybody. As mentioned, my name is Nicole Rossum, and I'm a hematologist at Ampath, and I'm currently working in the Department of Genetics. And I thought because I'm no longer exposed to routine hematology, I would try to do my current department justice and pick a topic that has genetic origin. And thus we will be discussing CHIP today, or clonal hematopoiesis of indeterminate potential. And just for the purpose of transparency, I just want to mention that I did not come up with this title. When I did my literature research, there was a paper published in Clinical Cancer Research in 2023, and I just don't want to be sued by me. So this is the topics that we'll be covering. We'll define what clonal hematopoiesis is, and then specifically talk about CHIP, what the risk factors are, why we should care that there is an entity like this, and then what are the unanswered questions regarding this topic. So aging is associated with a steady increase in the number of acquired, also known as somatic, mutations, and this happens in all tissues of the body. And the reason or reasons why this happens is primarily attributed to the cumulative effect of DNA damage and also the decline in your DNA repair mechanisms. So the cellular repertoire that you are born with is very different to the one that you have when you're older, in late adulthood. And this is often referred to as somatic mosaicism. The type of somatic mutations that we can get fall into one of four classes. And I apologize for this slide. I know it is very technical. It's just to reflect, as I mentioned, the four possible types of mutations or somatic mutations a cell can acquire during aging. Firstly, we have a process called deamination, which affects the methylation of DNA. And this change in methylation is often referred to as the signature of aging. And methylation is very important. Sorry, apologies. And a phenomenon known as epigenetics. So every cell in our body, when we are born during embryogenesis, contains exactly the same DNA, but some of our cells decide to become myocytes, some of our cells become hematopoietic cells, some become skin cells, etc. So it's not the DNA that you have that's important, it's what you silence and what you express. And that is where methylation is important. Secondly, as we age, we get more and more double-stranded DNA breaks, and these breaks can then be incorrectly repaired and resulting in either additional insertion of genetic material or loss of genetic material. Thirdly, when every time a cell goes into the replication cycle, errors can occur. And so as we age, more and more replications have taken place within a cell. And so the greater the chance of replication errors. And lastly, we can have large structural variations, mostly seen on a chromosome level. And this can be also large losses of entire chromosomes and translocations. Apologies for my voice, everyone. I hope it makes it to the end of the presentation. So these somatic mutations occur in all the tissues of our body, but it is most well described in hematopoietic stem cells. And it is estimated that in an adult human, we roughly have 50,000 to 200,000 hematopoietic stem cells. And each of these cells, oh, thank you, each of these cells can acquire one exonic mutation per decade of life. And this then results in a very heterogeneous population of cells with a broad genetic diversity, each possessing its own unique set of mutations. And taking the above into consideration, at the age of 70, we expect that you'll have 1.4 million protein coding variants, which is roughly 70 mutations per gene, and at least one hematopoietic stem cell. And let me just take a sip of water. If a mutation is acquired, and it has a neutral effect or it has a deleterious effect, then obviously that cell will not expand. However, if that mutation imparts to it a survival advantage, then it has a competitive advantage above all the other cells within the environment, and it will lead to expansion. And this is then known as clonal expansion, and the cell of origin is then referred to as the clone. And so clonal hematopoiesis is then defined as an outgrowth of a single clone, and it is highly prevalent in the elderly. And that is also well documented in various studies and is attributed to the factors that I've already mentioned. But it is not only a phenomenon in hematopoietic stem cells, but also noted in other tissues, such as in the esophagus and the epidermis of the skin. We know that hematological cancers, such as leukemias, are defined by clonal hematopoiesis, but can clonality also occur in a patient who has no evidence of malignancy? And thus research began. And the 1990s provided the first evidence of clonal hematopoiesis in the absence of cancer. So during embryonic development, females randomly inactivate one of the two X chromosomes, and this inactivation is maintained throughout that cell's lifetime. So researchers then discovered that a pattern of non-random X inactivation, so preferentially one X is inactivated, and this is then a sign of clonality. And this study revealed that this non-random pattern of X chromosome inactivation increases with frequency as the patients age. And then later in 2012, another study found a mutation in a gene called TEC2 in about 5% of elderly women who also had non-random chromosome X inactivation. And thus this was the first demonstration that a mutation in a gene can also drive clonal hematopoiesis in healthy individuals. In 2014, 3 groups of researchers examined sequencing data that was connected for genetic association studies. So these studies actually wanted to look for genetic risk factors for schizophrenia, diabetes, and various solid tumors. But these patients or subjects were not selected based on hematological phenotypes. It was quite a large population. It consisted of about 30,000 individuals, and they looked for any potentially described mutations. And so they would postulate that looking at such a large population, that one would find every mutation described in this population or in this large population. But there were a few surprises. So you didn't see just an array of different mutations. You saw that the mutations were restricted into a certain set of genes. And secondly, one would think that the most important genes that would be affected, that would give you a preferential advantage, would be your oncogenes or your tumor suppressor genes. But these were actually in the minority. Instead, 2/3 had mutations in either TEC2 and DNMT3A genes, which are very important in epigenetics, in other words, what genes get expressed. And the third most common gene was the ASXL gene, which is also an epigenetic gene. And then the next large group was splicing genes, which are important in cell division. And this question still remains. Why would TET2 and DNMT3 mutations and ASXL1 mutations lead to clonal expansion? So we could think that if you get a mutation that gives you cellular proliferation like JAK2, where you don't need a growth signal and to multiply, that would be of benefit. But how would something like TET2 and DNMT3A play a role, and especially seeing that they have opposite functions? So TET2 is a protein that has a methylation role. As soon as a gene is methylated, it is silenced or there's decreased in expression, and DNMT3A has a demethylation role, which allows for a gene to be expressed. And these questions are still unanswered, although there's ongoing research about it. The second less surprising observation is that clonal hematopoiesis is age-related. So less than 1% of individuals under the age of 40 had evidence of clonality, but this increased dramatically as we age, and about 10% of persons over 70, 12% of patients over 80, and nearly 20% of patients over 90 have clonality. And these populations weren't small. This wasn't 0.1% populations. The median was about 18%. So 18% of circulating cells were clonal cells. However, the prevalence of clonal hematopoiesis in a population is largely dependent on the sensitivity of the method that you use. And it's still undecided what percentage of clonality is relevant. And what is the significance of even a very small clone? This slide summarizes various studies that looked at the prevalence of clonal hematopoiesis in patients over the age of 40. And you can see that the deeper you sequence, the closer you look for clonality, the smaller the population that you can detect, the higher the prevalence of clonality within a population. So Faber and colleagues, they looked at allele fractions of less than 0.1%. And if you use that, then nearly 100% of patients above 80 will have evidence of clonal hematopoiesis. Now we've finally come to the topic at hand. So CHIP, as mentioned, is clonal hematopoiesis of indeterminate potential. So mentioned already, there's an outgrowth of a single hematopoietic stem cell that outcompetes its family, regardless of the cause or the underlying disease state. We then refer to this as clonal hematopoiesis. We know that hematological neoplasms, including AML, CML, myeloma, lymphoma, these are all clonal diseases. But with the newest discovery, we need a new definition because we are finding this in people with no hematological disease. And so the entity of clonal hematopoiesis of undetermined potential was created. The indeterminate refers to the medical uncertainty. How significant is this finding? Is it similar to something like MGUS in myeloma, where it's a precursor state of MDS or AML, or is it less relevant than that? The diagnostic criteria for CHIP requires the presence of a somatic mutation that is associated with a hematological neoplasm, but in the absence of morphological evidence of a hematological neoplasm. So there mustn't be any cytopenia, there must be no dysplasia if you either look at the peripheral blood smear or the bone marrow. And the variant allele frequency, or the percentage of this variant, needs to be at least 2%. But if studies show that a smaller percentage has clinical significance, this definition may change. So where does CHIP fit into the bigger picture? Depending on the combination of three findings, cytopenia, somatic mutations, and dysplasia, we have 4 potential categories. So if all the boxes are ticked, then the diagnosis of MDS applies. However, if you only have a mutation, no cytopenia, no dysplasia, no chromosome abnormality, then CHIP applies. What are the risk factors for patients to develop CHIP? So we have already repeated many times that it's aging, but there's also some environmental factors that seem to increase one's chance, such as smoking, being male at birth, exposure to certain chemotherapies or radiation, cytotoxic therapies, as well as evidence that your gut microbiome can impact it. And it was also seen that there is a certain genetic predisposition, which is still ill-defined, with certain families having a far higher propensity to develop CHIP. We have defined CHIP and what it is and what the risk factors are. Why does it matter? Is this just an interesting fact for the patient, or does that, will induce anxiety in both the patient and the clinician, or should we pay attention to this finding? So let's start with the most obvious implication. CHIP and hematological malignancies. Do patients with CHIP go on to develop a hematological malignancy? So 2 studies were published in 2014 in the New England Journal of Medicine. The first study reported a 10-fold increase of patients with CHIP being diagnosed with a hematological neoplasm, and the other study reported that 4% of CHIP carriers developed a form of blood cancer over the subsequent 8 years, which roughly translates into 0.5% of CHIP cases per year, converting to a malignancy, which is similar to MGUS. Later in 2018, another study looked at a very large population, and this was published in Nature and Nature Medicine. And they reported a 3 to 5-fold increased risk of developing AML in subsequent years. But they were looking at far smaller clones. They looked at less than 2%. In other words, not per se the definition of CHIP. And that is why the fold increase was a bit lower. However, what they did find is that certain mutations had a very high risk of that a person developing AML. So mutations in the following genes: TP53, JAK2, spliceosomes, which are SF3B1, SRSF2, and UTF1. Those patients particularly had a very high risk of eventually developing AML. And then further studies confirmed this. So not all CHIPs are created the same. Not all CHIPs have the same implications. If you have more than one mutation, and if your allele fraction of any of those mutations is above 10%, and the somatic mutation is of a specific set of genes, your risk is far greater to develop either AML or MDS in future. And it is so great that there is a belief that in future, these patients might be recategorized as having MDS already, if they have these high-risk features. Then we must make special mention for patients who receive cytotoxic therapy for solid cancers, so not for hematological cancers, for solid cancers. And one of the feared complications in these patients is that if they get exposed to the cytotoxic therapy, is that they can develop a secondary neoplasm referred to as therapy-related myeloid neoplasms. And these neoplasms have a dismal prognosis. And several studies have shown that a patient with CHIP who is treated for solid malignancies has an increased risk of developing this complication. And initially it was thought that the therapy induces or causes this mutation, but we now know that the clone precedes this. The clone is already present even before the patient starts cytotoxic therapy. But this mutation within that cell allows it to go into the cell cycle, even if there's cellular damage. And so that clone survives and can multiply. So unlike T2 and DNMT3A, which are common in the other populations, in these populations, we see mutations in your tumor suppressor genes and your oncogenes, including TP53 and PPMYD. What about stem cell transplantation? So the answer is it depends. If your donor has a CHIP, it will induce a greater immune response within the recipient, or a higher rate of graft versus host disease. And although this can be very life-threatening, the greater immune response entails that it not only attacks the host cells, but it also attacks the residual leukemic cells that are left within the recipient, and thus leads to reduced relapse of the leukemia. However, if the donor has a TP3 mutation, then the recipient can develop a new leukemia derived from the donor's cells with this TP3 mutation. In autologous or autologous transplants, in other words, you are both the donor and the recipient, CHIP is associated with inferior survival and increased risks of developing therapy-related myeloneoplasms, and these patients have a very delayed recovery post-bone marrow transplant. Now we're going to look beyond hematological disease. So most clonal expansions are expected to increase the risk of neoplasia in the tissue in which they arise. But hematopoietic stem cells are different. They are not restricted to the tissue in which they come from. They circulate throughout the body, they go through all the organs, and thus they have the potential to impact a wide range of disease states. And also because hematopoietic cells give rise to immune cells, CHIP is regarded as a pro-inflammatory state, and of course this has far-reaching consequences. If we look at CHIP and cardiovascular disease, several studies have found that CHIP is associated with a 30 to 40% increased mortality risk. And when they looked deeper, they found that this cannot be explained by cancer death, but it was actually because of cardiovascular mortality. So these patients' risk of future ischemic stroke and coronary artery disease was more than double. In fact, the risk conferred by the presence of CHIP was as great, if not greater, than the risk of other well-defined known risk factors, such as your LDL cholesterol, smoking, and hypertension. Because of this finding, further research was undertaken to understand the relationship between the two, and the following is a summary of the various findings. So the risk of early onset myocardial infarction, which is defined as myocardial infarction in women under the age of 50 and in men under the age of 40, was 4 times higher in patients who had a CHIP. If your mutation was a JAK2 gene, you had a 12-fold higher risk of having cardiovascular complications. And the risk was also correlated with the clone size. So the higher or the bigger the clone size, the greater the risk. CHIP carriers were also more likely to have coronary artery disease. And, to have coronary artery calcifications. And CHIP was also associated with a 25% increased risk of first episode hospitalization heart failure, independent of any other traditional risk factors, therefore. If we look at CHIP and further at CHIP and cardiovascular disease, there were 2 studies, or there was another study involving about 50,000 individuals, which they gathered from 2 separate biobanks. And they wanted to look at the association of CHIP and peripheral artery disease. And they were able to document that CHIP has an impact on other atherosclerotic diseases, including coronary artery disease, aortic aneurysms, and mesenteric ischemia. And the thought behind this is that because your hematopoietic stem cells give rise to macrophages, that clonal hematopoiesis would give rise to aberrant clonal macrophages, and these may have altered functioning and contribute to inflammatory phenomena around atherosclerotic disease. So based on sequencing data of 3 community-based cohort studies, and including participants that were over the years of 50 years and older, the researchers tried to see if CHIP has an effect on cardiovascular disease, does it also have an effect on renal disease? So the CHIP was then linked to a 30% drop in both glomerular filtration rate, slow post-injury healing of acute renal failure. And if you had chronic kidney disease with CHIP, you had a double risk of having end-stage kidney failure within a 5-year period. I think with any of these studies, and especially of the ones that we're going to be talking about in the next slides, we have to think of which came first, the chicken or the egg. So do certain disease states promote CHIP formation, or does CHIP lead to the development and progression of the disease, or is it a very complex interplay between these two? And because of this uncertainty, the following associations require further research. So it was found that there's a 30% increased likelihood of patients with CHIP to get diabetes or type 2 diabetes. They also have an increased propensity to get COPD, but we know COPD can be caused by smoking, as can CHIP. So one's not sure about that relationship. CHIP carriers are more likely to contract pneumonia, have a higher risk of contracting bacterial pneumonia specifically. And patients with CHIP, especially with a very high allele fraction, have a twofold increased risk of chronic liver disease, hepatic steatosis, and liver cirrhosis. CHIP and infection, there is a lot of research, a lot of articles out there. I decided to just look at HIV because of our demographic. There was a study done in South Africa. They looked at 446 patients, which included 202 HIV positive patients and 226 HIV negative patients. And the HIV positive patients had twice the level of clonal hematopoiesis than those that were HIV negative. And ASXL mutation, which we know was the third most common mutation, that was the most common mutation in HIV patients. So something in HIV infection favors the growth of this clone. It was also observed that the allele fraction of whatever mutant clone you had was much higher in HIV positive individuals than those with CHIP if they were HIV negative. Because clonal hematopoiesis stem cells give rise to immune cells, the next possible thought would be that there is a connection between CHIP and autoimmunity. We also know, as mentioned, that CHIP is a pro-inflammatory or induces a pro-inflammatory state. And studies, there's numerous studies, and I didn't mention all of them, but the one that had most concrete evidence was the connection between CHIP and ulcerative colitis, and also an increased risk of ANCA-positive vasculitis. So I just wanted to make everyone aware of this new syndrome. I don't know if you've heard of it, VEXA syndrome. So it stands for vacuoles, E1 enzyme, X-linked autoimmune somatic syndrome. It is associated with the acquisition of a somatic UBA1 mutation, and it leads to multi-system adult onset autoinflammatory disease. And about 24 to 50% of these patients will have or end up having MDS. And you can see there on the picture, they can present with a lot of manifestations involving every organ system. So this is definitely evidence that the clone can have quite a significant impact in an autoimmune arena. So a little bit of good news is that in patients with hematological diseases, neurodegenerative diseases are less common. And this is consistent with the finding in CHIP, which is associated with a reduced risk for Alzheimer's dementia. And they think it's because of the altered phagocytic activity of bone marrow derived microglial cells that are enriched in the brains of individuals that have CHIP. Okay, so this is just a picture to sort of summarize what we've just said. So as we can see, some of the things that I haven't mentioned is association with osteoporosis, because osteoclasts are also hematopoietic stem cell derived. So there's increased bone resorption. Female patients have evidence of having premature menopause if they have CHIP. Patients with CHIP have accelerated aging. There's increased risk of having thromboses, increased risk of gout. And the only silver lining is the Alzheimer's dementia. That's the only thing that has decreased the risk. So the next question then being, with all this information that we've just gone through, should we be screening the population for CHIP? And is it, and the answer is not easy, because testing with CHIP comes with numerous disadvantages too. Testing is very expensive, and it will most likely not be reimbursed by the medical funders. Also, now the patient is left with this information, this cloud above them. And most of these patients will never develop a hematological malignancy or may never have a complication. But the idea of it can create a lot of anxiety for the patient. Currently, there's a lack of consensus guidelines for the screening, diagnosis, and management of CHIP, but the need is growing because we are sequencing DNA ever more, whether in a diagnostic setup, or some patients even have point-of-care testing, which they undergo. And often CHIP would then be an incidental finding. So currently, there's no recommendation that you should screen unselected patients for CHIP, but there is a thought that it might be appropriate in selected individuals, especially individuals who have premature and unexpected coronary artery disease, especially in the absence of traditional risk factors, as well as in patients who are going to receive cytotoxic chemotherapy for solid tumors, and in patients that will go stem cell transplants, or the donors that will give the cells to the recipient. And if we do go down this pathway, we need to counsel these patients. We need to inform them that there is currently a lack of evidence regarding how to manage the situation. And because the association between cardiovascular disease and CHIP is the greatest, treatment at the moment would be to modify all known risk factors, incorporate lifetime changes. And because we know CHIP has a very strong atherosclerotic component, if a patient has CHIP, it would favor the use of statins in a patient with cardiovascular disease, or in a patient that is of advanced age. Aspirin is a little bit of a problem because there is a possible association of increased risk of intracranial hemorrhage in patients with CHIP. So in conclusion, clonal hematopoiesis is a fascinating glimpse into the end result of decades of mutations that occur in our body and the natural selection of these cells. And although we once thought it to be very rare, we now see that it is quite prevalent, and it has a broad array of potential health implications. Although our knowledge is growing exponentially on the topic, many questions are left unanswered. Can we reverse the effect of CHIP? Are there drugs that can be developed to target the mutant clone? Which populations could potentially benefit from screening? Exactly how this can interact with all other diseases that are still yet to be studied. And once CHIP has been documented in a patient, how do we follow up that patient? Does that patient require follow-up at all? Okay, and that's it, people, and my voice made it.
Oh, thank you. I think you caught my attention here. I think this was quite amazing. Never thought of the link between that and COPD. But yes, it's true that there are actually quite a few cases. They did quite a few cohort of study that actually linked the two. I think because most of them really not related to aging, then most of the thing, yeah. the question that should we be screening all our COPD patients?
I think with things like that, it's so difficult because you open Pandora's box to an extent. You know, if you go looking randomly for things and you find something, you always need to think what are you going to do with it? Because
Because I'm also thinking from a hematological point of view, the only reason I do like an NGS on a patient, would be if there's a cytopenia or the patient's symptomatic. I wouldn't randomly go and do it because you won't get reimbursement. You already have to motivate to the medical aid to get an NGS panel on a patient with a hematological disease, So,
One question. No, regarding Chip, and you talked about it and HIV. So is this HIV patients who are on ARVs, virally suppressed, or is it just?
I don't think they really subcategorize them, unfortunately. I don't think, but it would be interesting. One would expect the more rampant HIV and the inflammation that's caused by the higher the chip fraction. We're starting to see, because we put sequencing of TP53 for CLL and things like that on a big panel. And then we get these incidental findings. So we're starting to see, and then you don't know what to do about it. The patient doesn't have the cytopenia and they've got a variant that is completely unrelated to the CLL or the myeloma or the whatever you sequenced for. What to do about it.
At least if they've got a diagnosis,
But
if they don't, that's the challenging part.
But you know what? The most important is really, I think the highlight here is that I think we don't know much about medicine, and actually what we know is just a minute of it. And I think this really say that, I think we have to have ongoing educations, and most of the time I think before you write any patient off because you reach your limit of your knowledge, I think consult again, and probably I think there's always a way of reaching to the FC ways, the problems, and I think for me, it's an eye opener. So it's kind of a very good presentation. And also, it tells me that perhaps maybe we should look more on those atypical presentations of patients that we can't find anything. I have a young girl that presented to me now, and she obviously been to your clinic there, I think was seen by yourself and everybody else. Patient was really but up to now, we can't have the diagnosis. A lot of things just don't add up. And I think because our knowledge, we're not doing our testing capability first is limited. And let alone have the knowledge, because you only test what you know. Now, if you don't know, in the past, I would not even have thought of this at all, and let alone even maybe there are thousands of patients that already has passed through our practice that we actually known, but we don't know that this exists. And that, I think, where our biggest problems are. And I think we should keep continue presenting topic like this, because just widen your horizon all the time. And that's the beauty about it. So perhaps we could develop kind of screening criteria one day for those, typical presentations, and just have a look at how many we can actually pick up, 1 to 2 or something like that.
What is the cost of screening?
Expensive. It's about 8,000 to 10,000 rand. If you're going to look for, every relevant gene.
But I think there are patients that can be offered exactly. Those were probably the early present with COPD. I recently had a very young colleague that presented with, a typical picture would look like just like obstructive bronchiolitis. And when you do all the tests that all of them are negative. But the patients now struggle. She can't even walk far because, arguably, the lungs are so distended that it's unable to expel the air. But it's not asthma, it's not COPD, it's none of the above. We just have to be something that's causing it. The question that how far do you go inside actually to start looking into it? I think, so maybe some that we should start digging in. We should start and have those kind of discussions. I think for me that would be a lot better. Yeah, that's perfect for you.
What's the thing with the ice creams? Do you just like ice cream?
I always pick a theme with a presentation and then I go with it.
Visualize for genes.
Nicole, you can exit.
Oh, sorry.
Sorry, guys. Any question online?